Recording. Excellent. Good evening, everyone. This is the Iraqi Australian Medical Association virtual conference. One of these conferences we used to organize once a month. راح نحكي بعراقي وإنجليزي. So today we have just try to, where's your Rima Hadi? So Dr. Rima Hadi is a plastic and cosmetic surgeon, 10 years in private practice, and she holds an FRACS in plastics since 2016. She's got masters in surgery since 2010, 3 years as an advanced surgical trainee, general surgery, 5 years advanced surgical trainee in plastics, currently enrolled in Juris Doctor, low 10% completed, and that part of her work as well in Medical Council Board, Carina Private, and she works at Carina Private Swan Clinic. So Dr. Rima, the slides, the microphone is for you now, and you can start the meeting.
هلو أهلا وسهلا بالجالية العراقية شرفتونا إن شاء الله مفيدة للجميع بس راح أحول على إنجليزي يمكن أسهل بس إذا أحد عنده أي سؤال بليز اسألوني يعني هذا very much interactive وإن شاء الله تكون مفيدة للكل. So basically there've been a lot of changes over the last 2 years with who can do cosmetic surgery, and there was a lot of kind of territorial dispute about cosmetic surgery versus plastic surgery. And essentially the government and the court system have basically decided in APRA that they're going to create a new body called the Board of Cosmetic Surgery. And within that, the board can include plastic surgeons, and it can include people who are cosmetic surgeons. So they can apply for accreditation, and I think moving forward, they will also let ENT and general surgeons apply as well. And I think the reason for that is to kind of ensure safety for the public, because for a long time, anybody could kind of call themselves a cosmetic surgeon. The most common surgical procedures in Australia are the following. So breast augmentation, blepharoplasty, sorry about that bracket, liposuction, rhinoplasty, facelift. And I think moving forward, really number 3 used to be number 1. And I think number 3, which is liposuction, will drop down even lower down the list, because I think the role of the GLP-1 agonist, I mean, I write it a lot, and I refer people to bariatric surgery, means that people who only have a little bit of weight to lose can have that before needing liposuction. And I don't know what the role of liposuction is going to be in the future. Certainly, I'm doing a lot less of it. And that's a good thing for the patients, and I think it's better for their health. I'm sure our esteemed cardiology colleagues would agree. When you look at the most common non-surgical procedures, I mean, I don't know about your areas, doctors, but everybody in my area gets their hair done every 3 months and gets their Botox done every 3 months. It's not something I personally do in my clinic, but I think these all prevent, I guess, surgery or delay surgery or even improve the outcomes of surgery. So you're having fillers and needling, and there is all this radio frequency. There are also topical agents such as exosomes and growth factors, chemical peels, IPL and light, PRP, thread lifts, and minimally invasive facelifts. Then you have that category of cryptolysis, cool sculpt, HIFU. And anybody who wants to introduce these into their practice, I guess the only word of advice is, apart from making sure you have training in it, is please make sure it's been TGA approved. There have been complaints to the medical board where things are not TGA approved get used on patients who may or may not have an adverse outcome. And it's basically illegal to use things that are not TGA approved. So even if the company says it's TGA approved, please check. The next thing I was going to talk about is kind of how to avoid complications in plastic surgery and cosmetic surgery. And I think, honestly, way I think about it is you divide it into physical, mental, and then the timing of stage of life. I think when you look at someone's physical, certainly for surgery, I always go for BMI of less than 32. And increasingly, there's a move towards a BMI of less than 30. I try and get everyone to stop smoking. And of course, the medications that blood thinners, and there's a lot of them on the market that are herbal, like fish oil, krill oil, ginseng. I think it's especially important to make sure that the patient stop them at least 2 or 3 weeks ahead of time. I mean, of course, the other thing is if they see a specialist like your esteemed colleagues, I would always get a letter from their GP, but I'll also make sure that that the specialist clears them. If they have a cardiac history, then a cardiologist needs to clear them. I think in terms of mental screening, 2 years ago, the government said we should screen for mental health. And I think it has been a very good thing for my clinic because 2 years ago, the patient comes with mental health problems, and I find it very hard to say no without the patient feeling rejected. Now I can say, I'm really sorry, APRA said you have to go see a psychologist. And most psychologists will either say no if the person's not suitable, or they say they need more work. And Alhamdulillah, my life has been so much better because I can easily say, I'm really sorry, I can't operate. The other thing that's been really helpful, of course, is the doctor's letters from their GPs, because even if they say this patient should not have surgery, they don't say that. They say, oh, this person has a history of major depressive episode, and I understand that to be coded for this person may not be suitable. Or they say this person has a history of mental harm. And that single-handedly has really improved the quality of my life. Nobody wants to operate on these patients. They cause endless grief. And the final thing is timing or stage of life. So, do they have support at home? If she's planning more children, this is a bad time to have plastic surgery. So I think if they're losing weight, also a bad time to have surgery. So I think it's really important to think about why they want to do this and also, is this the right time for them? This is the body dysmorphic disorder questionnaire. I think they will start to introduce this for other types of surgery as well, because it is a screening tool for body dysmorphia, but reality probably also screens for anxiety and depression. This is another one from an ENT surgeon from Turkey. I can only feel sorry for the poor man who wrote this questionnaire because God knows what kind of patients he has wanting nose in Turkey. But it's questions like, if your friend got hit by a car, do you chase the car or do you stay to help your friend? So I think, this is obviously a worldwide phenomena with the increase in social media. It's impacting a lot on people's mental health. And I'm seeing it, you're all seeing it. And I think moving forward, we're going to have to think carefully about the patient's mental health, not just the medical side. This is the cosmetic questionnaire. There's so many, the poor patients that come in. I've become a psychologist in my later surgical years just to make sure that they've been screened appropriately. And I think it's very interesting. The next thing we talk about is the kind of technique. Sorry, I feel like, yeah. The next thing we talk about is when you do a procedure, how do you protect yourself from a non-surgical procedure and a surgical procedure? And I think the first thing is you think about being risk averse. So anybody here who does injectables, and I think increasingly this is part of many GP clinics, many GPs are asked to supervise nurses who do this. Certainly having for filler, I think filler is the greatest danger. Botox, I feel like is pretty safe. Even if you've got eyelid ptosis, you can give eye drops, the patient will be okay. But I think filler has the potential risk of blindness. I think a really careful consent process, making sure you have Hyalase, making sure you have a protocol in the actual clinic that's written. Refer emergently, inject Hyalase. There's a protocol. Emergently refer to emergency department for further treatment. And I think it's really important to kind of protect yourself and the patients as well. Of course, stopping blood thinners and screening for patients with unrealistic expectations. I think that patients who are having injectables and any non-surgical cosmetic surgery would probably benefit from having the mental health screen as well. The next thing we're going to kind of talk about is how to deal with complications. I think if the complication belongs to someone else, please refer them back. They want to know. It's easier for the same person to manage it. I think everybody has to give a phone number by law now for an after-hours emergency. Filler blindness can present many hours later. But certainly for surgical cases, it's part of the law now that you have an after-hours number. Please let them call them. If the complication is skin excision or a dehiscence, you can refer to emergency. If it's the person, for whatever reason, is not contactable, then they will then find that person. If it's blindness, follow the protocol. If the complication is cosmetic and you have done it, like a GP has done it or another specialist has done it, you can always refer early for advice to help the patient. We're all kind of diverse in our practices. And I think, we always, this field is changing a lot. There's always new techniques, there's new machines. I think the way to avoid, and the patients want this. Like, I'm under pressure. Can you do threads for me? I'm like, I don't really want to do threads for you. It's not really my field. So I don't. But eventually things become mainstream and you kind of have to adopt them. So I think, the idea is that don't do too much on the first day with patients, for example, for filler or Botox. As I mentioned, check the TGA approval. The companies don't always tell the truth. I mean, God knows I believe them when they say that it's TGA approved. I never check on the TGA website, but you have to, as a physician, it's your imperative to check. I wouldn't overpromise. I wouldn't do any risky procedures with a low chance of success. As I mentioned, make sure you've done the training with the company or done the course. And when you start, do a stepwise approach and gradually build on the skill set. I think check that you're covered with your medical indemnity. I think it's really important because the medical companies also don't want to deal with this, the indemnity companies. One of the council complaints was a doctor who they then said, oh, well, we're not covering that. I mean, it's kind of horrific doing surgery. You get a complaint or the patient is not happy, and then to find out that you're not covered for this procedure. Bit by bit, I think the medical board and APRA want us to kind of have well identified or well described delineation of practice. And I think the hardest thing I'm still learning is when to say no and also how to say no, because you want to make the patient happy, we all do. But knowing when to say no I think is a really important skill set. So what were the changes to the APRA guidelines? You have to have 2 consultations. One of them has to be in person. There's a cooling off period of 7 days before they can book, even for the second consult. You need a referral from the GP, which is full of very useful information, psychological screening, and the clearance from the psychologist prior to proceeding. So if they flag, I refer them, and then they have to bring the approval prior to proceeding. I think nobody wants an unhappy patient. We've all, sometimes nothing's gone wrong, but the patient is anxious. So I find that for me, the first 6 weeks, the patients are the most nervous because they have swelling. It looks weird. And no matter how many times I show them photos, it's sometimes hard to process that. So I find having a really supportive nurse who can sit and speak to the patient before I walk in to reassure them that they'll be looked after is important. And I don't need to tell you all how important having a good nurse in your practice is. Honestly, that she's saved me many times. And she's been a different nurse sometimes. They change, but at least it's someone who consistently knows who you are and backs you, and can with confidence say that you'll sort it out. Having a conference, family conference, I don't know. My patients never want to have the family involved because they often don't know what they've had done. Open disclosure, sitting down and giving the patient time. And honestly, the hardest patients to look after are the ones that you have to look after, but also to know when to refer. My job is becoming increasingly difficult. 1 in 3 plastic surgeons get sued every year. Apparently, we're number 3 behind orthopedics and neurosurgery. It's trying to work out, did you meet your expectations? Are you happy? Turns out there's now law firms that can help you get rid of bad Google reviews and Facebook reviews. And yeah, the whole part is very ugly. So the things that I have learned to try and avoid all of this, I'm just going to skip to this one and then come back to it. This is what I have found to be very helpful. Very clear explanations of what's going to happen and how it's going to happen. Our documentation has become like War and Peace. It's very long and very thorough, and it's been checked by the nurses, the receptionist, and any patient that can read it gives feedback to make sure that it's clear. A really clear, robust consent process, so they know exactly what's going to happen. A financial consent. What's this going to cost? How much do I get back? What happens if you need a revision? And then I draw a diagram of what I'm going to do surgically, and I get the patient to countersign it. I also have 2 3D cameras, but one of the 3D cameras, I send them a link to make sure they're happy, that that's what they're going to look like and that's what they're going to get. High definition photography without shadowing, so that the pictures can show clear before and after photos. And I think even if you're doing injectables, filler, threads, any of this, I think having really good photography with dates will really help you, because the patients never remember what they look like. And the best is showing them a before and after photo of what they look like, particularly at 6 weeks, because they can usually see a very big difference. Of course, it's always better a year later, but at least in the first 6 weeks while they're feeling anxious and have swelling, We even started taking photos on the table just so that they know what it's going to look like as well. An after hours number that's held by my nurse. I carried it for 7 years, but I think the nurses are better at it. And that way they can reassure the patient. And of course, I'm always contactable if they need me. The only other thing I was going to share with you is, I'm a surgeon. I did general surgery, then I did plastic surgery. To me, the word trauma means surgical trauma, but now it means mental health trauma. Now, I don't know what happened in COVID or social media, but I feel more and more that we have to be careful with the patients because I don't know what's happening in their life. And I'm seeing them as surgery, but they've been through sometimes more than what I see. So I did this course with the Blue Knot Foundation about 2 years ago. Um, and, I got taught again fright, flight, but now there's freeze, which means really I've stopped doing anything under local anesthetic because I can't tell if the person's happy or not happy. How do I know they've withdrawn consent halfway through? So procedures like upper eyelid surgery, I was doing a lot under local. I think I did 1,000 under local anesthetic. Now everybody gets sedation with the anesthetist because I think increasingly with, again, I'm going to throw my law stuff in there, mental health, although at the moment you can't separate it from physical harm, it's moving towards you could claim mental health trauma from a procedure that was painful. So now I'm careful, even if they need a minor revision, sorry, we'll just do it under sedation. It's easier for me and easier for them. And, I think we've learned a lot. Before, we always used to think the patient who is nervous, why are they reacting like this? Sometimes they're angry, sometimes they avoid you, they don't come back for follow-up, sometimes they disassociate, they self-harm, there's drug and alcohol. And I think with the ACE studies and looking at childhood trauma, and I think COVID certainly contributed, be understanding that sometimes patients' adaptive systems are not helpful to coping with surgery. So I think to protect, honestly, I feel APRA's done us a big favor. I have no idea why some surgeons sued APRA. The best thing they ever did for us was to screen people for mental health. Because people who are mentally not well should not have any type of surgery if it's elective. This is, at the end of the day, supposed to be something that improves your quality of life, but it's certainly not life-saving. And I think drawing that distinction has been very helpful in my clinic, and whatever I can share with you, I hope is helpful for you too. And remember, 99% of patients are happy. 1% need extra support and love, but inshallah that they'll be okay too. And that's about it. I was just going to share this photo with you all. I got dragged by my friends to Langkawi after Ramadan. And I have to say, beautiful country with beautiful Muslim people. In the spot in the middle of nowhere, the people were so nice, and it shamed me that the Malaysians better Muslims than a lot of us. And you could see the kindness in their hearts. So shout out to Langkawi, a very cheap holiday with lovely people. And thank you very much for your time. I was going to ask if anyone has any questions.
Excellent talk, Rima. Thank you very much for the presentation. And we open up the floor for any questions. So please, you don't need to raise your hand, just unmute and ask the question, please.
Yes, Dr. Rima, thank you very much for such a precise and very summarized presentation. We have some question related to more details into all these aesthetic procedure. You know how widely now the use of these procedures there, to the extent that I think it's hard, and there are places who are very busy. My first question is about the Botox. Can you tell us, doctor, about the sustainability of Botox and its effect in the skin? I have a good idea about the sustainability in relation to achalasia, where we inject Botox at the end of the esophagus to treat this spastic condition, or also to treat gastric outlet obstruction, and also to treat the anal fissures. I have some idea, but in relation to the skin, do you have an idea about or you tell us, definitely you have an idea about the sustainability? That's one. Secondly, what's the impact on the natural collagen from the repeated use of Botox?
Yeah. Okay, so as you know, it binds irreversibly to the neuromuscular junction, and essentially the only way you can get movement in the muscle back is by replacing that receptor. It usually takes 10 weeks to 12 weeks to replace. Repeated use every 3 months means with time you need less and less. We also used it in children with cerebral palsy and in people who have strokes and in people who've had radiotherapy to the neck to reduce muscle spasm. It's a botulinum toxin, comes from natural product. In Victoria, I know they were using products that were not TGA approved, and 2 people ended up in ICU because it was from not a company that was approved in Australia with basically botulinum respiratory cause of failure. Thankfully, the patients were fine. So I think if you use it where do people use it mostly for cosmetic reasons? Forehead, around the eyes, to gummy smile, and to lift up the corner of the mouth. You can also use it on the neck bands for platysma. I think it is very safe. There's 2 main types. There's Botox and Dysport. Botox is like pinpoint, does not travel. Dysport is more like a scattergun approach. The units are different. So Dysport is roughly 2.5 to 3 times the units of Botox. Dysport's usually a bit cheaper as well. Some people say that Botox has less allergies because it's purer, but that comes from the company that says that. With time, the patients will use less and less. I don't think there's any problem with long-term safety. We've been using it on medical patients for a very long time. I would say at least 20 years. I have seen 2 people, not in my clinic, but I know of patients that came to see me who developed an allergy with long-term use, but we think it's from the impurity of the Botox rather than the Botox itself. If there are people who go, oh, you can't have Botox because over time, like it changes the face and you can't stop it. I think you can always stop it. I don't think there's an issue. I think if you over Botox someone, it can drop their brows and then they need eyelid surgery. And I say, don't do it, just reduce the Botox. But I think it's just a way of smoothing the wrinkles out. I don't do it personally in my clinic, but I don't have any issue with it at all.
What about the effect of the natural collagen, Doctor?
As far as I'm aware, it only affects the muscle. So you're right. With time, it causes muscle atrophy, but I don't, because it works on the motor end plate, I don't think it has any effect on collagen at all.
Have you come across cases where there is a loss of the natural facial expression from the repeated use of Botox? Have you come across this?
Yes, yes.
So I think this should be mentioned, Doctor.
I think so. I have had patients come. I go, look, I'm really sorry. I'm very concerned, but I can't move. No, I think the key to it is to always leave some, because I think if you overdo it, it also, like we're human beings, you're supposed to have some expression. I think it's just a fine sprinkle and not to overdo it.
Yeah. And what do you think? Sorry, I'm just trying to use this
Please.
to direct the attention for that thing. What's your thought on young people, young girls in particularly, with no wrinkle?
No.
They go for that. What's your?
No.
Because we come with this.
No, I've seen when I used to do it, they ask and I say, no, go save your money. This is crazy. I don't think anyone should have it. I'm going to say it, 35, 40. I think it's crazy these 20-year-old girls are having Botox. I think it's really wrong. I think you should only have it. It should be very low dose, only when the line starts to become permanent.
Right. Yep. Thanks.
Hello, Dr. Rima. Can I ask a question?
Hello, Dr. Wisal. Thank you for
Hi, Doctor.
all the ultrasounds for all the patients who have muscle separation.
Thank you so much. I'm glad to hear that
Great
you
reports.
work at
Thank you.
Thank you. Thank you. So hearing you're saying that Botox is safe and there's not much of long-term complications. So how come you don't do it to your clinic, if you wouldn't mind me asking?
Because when you have non-surgical patients, every patient is a separate patient.
Yeah.
So each patient needs their love and attention, and you have to really, and honestly, I did surgery because I love surgery. Just like you, doctor, you did radiology to hide in the room. I did surgery so I can hide in theater. And I feel like the nurses, I think many nurses and many doctors do this very well. Because if you do high volume and you have to spend a lot of time with them to make sure they're ready. And for me, if I do surgery or I do Botox, it's the same. It's still a patient who is happy or not happy. And I'd rather do
Yeah.
it where I kind of am trained in.
And you said like we need to check the TJ. Well, by the way, I've never done it. I'm too scared to do it. I feel like it might freeze my face, and I feel there must be a complication because I'm putting poison in my face. But it's actually encouraging to hear you saying that there's not much of complication. Talking if it's in good hands, of course. So my question, how do you know what they're injecting in your face? Like if you're going to a nurse even a GP who does a lot of these injections, what you go there and you scan the ampoule to know what type of...
Well, with filler, there'll be a sticker of the actual product on the paperwork. And with Botox, you can just say, can I see the bottle?
And what it will be written on it? It's TJ approved?
I would go, no, it would say Dysport or Botox. I think with those, it was from overseas. And I think my understanding is they bought it from Korea, although I'm not saying yes, Korea has lots of good products. But I think if the product is not written in English, doesn't say Dysport or Botox on it, then I would not use it. But people don't want to do the wrong thing. Most people want to do the right thing. I think that lady who was injecting them was not a nurse, she was a beautician.
Yeah, and that's I don't know how people would let themselves go through that.
It's
But
cheaper,
even
doctor.
but it is safe to do it with a trained nurse or a trained GP, you think?
That's right.
Yeah. And why are you against fillers? I could sense that you're not supporting.
I don't have a problem with filler. I think if you're going to have filler, it has to be someone who does it a lot. And I would avoid this area because it scares me because it has a higher risk of blindness. And maybe because personally, if I go blind in one eye, it will affect my work. And I really don't think any cosmetic surgery is worth going blind. I mean, no surgery that I do, I talk about blindness. So I think filler, I'm very cautious with. Avoid the T-zone and make sure it's reputable hands. Make sure that they have everything on standby, like highlighs. And they know it's supposed to use a cannula. It's supposed to pull back. So I think if start Botox, don't do filler to begin with.
Yeah, no, I used to say a lot of patients who done filler and come for us with ultrasound because they have a lot of balls in their face.
Yeah.
Sorry, thank you so much.
Sorry to interrupt.
I took a lot of your time. Thank you so much.
You can have a private conversation with Dr. Rima anytime you like.
I'm done.
Is there any other question, Dr. Ali? Do you mind if I ask Dr. Rima a favor? Can she go in 2 minutes through the complications of filler, breast reduction, and liposuction? Do you mind? Just one for the education. For the education, we come across a lot of complications. Yes.
Complication. Let's start with breast reduction / tummy tuck because they're body wounds. Could be arm, could be thigh lift. Main complications are wound breakdown, and bleeding, so hematoma, bad scar. I guess they're the 3 major ones. So if you, God forbid, dead nipple for breast reduction. So I think, again, refer back to the doctor straight away. That's their job. God knows, that's their responsibility. But if you can't, number 2, and it's urgent, send to emergency. Number 3, if it's an infection, swab first, then Keflex, because that's the protocol. Refer to ultrasound to look for deep tissue collection. If it's wound dehiscence, dressing, Gelinet, betadine, cover it, avoid a shower. If it's a hematoma that needs surgical evacuation, straight to emergency / back to the other surgeon. I don't think anyone should have to look after someone else's complication, surgically anyway. In terms of liposuction, liposuction has a lot of complications. It can cause dimpling. It can cause rippling. If you take too much, it can cause a dip or a contour deficit. It can cause burns from vasa. I think liposuction is you have to do more, not less, because the patient wants to be happier. I think they see a lot on social media of how the skin adheres to the fascia, and that can cause pain from the lack of fat, which is needed for a glide plane for movement. I think, yeah, like I said, if the world had no more liposuction, we would all be happier. If I could just write either a surgical weight loss surgery or a weight loss drug and avoid liposuction, except just for a little bit to complement another operation, I think it would be a good thing. Filler, the main complication is granuloma, but less so, as Dr. Wassal mentioned, because now it's dissolvable, whereas before people were using filler. Blindness, contour irregularity, and if you put it near the lower eyelid, it can cause lumping. So I think filler and now the fillers are better as well. They kind of gel and mold a bit better, whereas before they were very stiff and took a long time to break down and caused often quite a big allergic reaction, a kind of a hypersensitive reaction. Because I think they came from bovine collagen, whereas now it seems to be cleaner, made from bacteria kind of collagen. So yeah, in answer to your question, I think filler is good in people who are trained, but to kind of be cautious. And obviously, we've all seen the big overdone. Yeah, very bad.
Can I have a question? Last question, Dr. Ali.
Bushra, yes.
One very small question. Very
okay,
small.
let's go ahead.
Thank you, Dr. Reem. It was really amazing. What about the things they call the profilo? What is a profilo?
Yes.
My daughter asked me, she said, what is profile? I don't know. What is it?
Actually, it's basically an injection to simulate collagen. So these new things have all come out. This, I want to show you, Doctor. I had it on my neck. My friend did it for me.
So it's not a filler?
No, it's like a collagen stimulator. I think it's great. I think these new products are getting better and better.
What's the injection? What is it?
Honestly have no idea. I think it's the
hyaluronic acid, I think.
It's one of these, that's right. But it's not like filler. So they think it kind of sits under the skin as an injection and stimulates collagen production. I think it's good. I think all these things will help us in the future give better results for people's skin who want to, I guess, maintain working in the workplace.
Okay, thank you.
Dr. Ali, there is a question on the just a quick one.
So we should have given you the whole hour, Rima, to answer all the questions. Everyone interested in these topics. I'm just going to ask you one question from Lachlan Smith. He's asking about the use of estrogen cream to help thin skin of aging.
Doctor, this is such a very nice. Thank you very much for this question. So increasingly, the patients come to me and they are on different medications. So, and they go down two routes. Half the patients are on anti-inflammatories for no reason. So they basically take turmeric, fish oil, magnesium, sometimes black seed oil, and they seem to have good quality of life. The other half of patients are using off-label hormones. And it is a combination of estrogen and testosterone. They microdose. It's off-label. I mean, one of the doctors, she was an ex-GP, and she came as a patient, and she said to me that, I mean, she looks great. She's 70. She looks 20 years younger. And she was like, yes, but my voice is very low because the testosterone we used was not the right one. But now the testosterone is better. I think I'm 45, so I can say this. Women in their 40s are facing many challenges. So I think you can have normal blood test, and women are taking estrogen. They are taking these. So the patient said to me, I just put a little smear. Some people are taking patches, because I think increasingly, if you are perimenopausal, your blood test can be normal, but you're still exhibiting symptoms of menopause. So they're starting to use patches earlier, because we know that not only if you don't, within 2 years, the patients swear to me, they bring me photos. If I don't take estrogen, this is what happened to my face. So I think increasingly they're using estrogen patches and estrogen gels, and also to prevent osteoporosis. Now, I'm not going to talk about the cardiac or breast cancer or gynecological risk of cancer with these medications, because I think, increased risk of DVT. So I'm not at all saying it's not something I prescribe at all, but they are using it and they think it improves the collagen. And yes, I may have started using the patches last night. But I swear I'm getting hot flushes, I swear. So I watch this space. I think, and this is, I haven't even mentioned all these vitamin infusions. Where is the evidence? I remember talking to my uncle about this. He's like, this is terrible. We wouldn't have vitamin C infusions and
terrible.
Where's the evidence that this works? Hormones, I understand your estrogen level's low. We supplement it to improve your quality of life. I get it. But, we're using these minerals and vitamins that have no evidence at all. I think there's a big wellness market that's taking advantage of patients.
Yep.
Excellent. I'm actually stop here and move to the next talk. Look, thank you very much, Rima. I think this is a great talk. And
we can always do a second one, Doctor, supplementary.
Absolutely.
We'll
book you for the second one. So we'll organize a second presentation for sure. So everyone enjoyed your talk. Thank you very much, Rima. So I think we move to the second talk for the night, Dr. Fidel Matti. We're talking about lung cancer and public screening. So Dr. Fidel Matti is a consultant respiratory and sleep physician. And the screening for lung cancer has become more and more topical. So Dr. Matti, do you want to share your screen?
Hi, everyone. Yeah, thanks. I'll do that now.
Sorry, Fidel, sorry to interrupt you. Do you mind if you present yourself, because you didn't send me anything about it?
Sorry, I've been hammered with the bronchoscopy stuff lately. I don't know if you can see this.
I can see your screen, yeah.
So my name is Fidel Matti. I'm one of the respiratory and sleep consultant. I have a big interest in two main areas of respiratory medicine, including bronchoscopy and pleural intervention, as well as pulmonary vascular disease. That's why I do a lot of work in Sydney Southwest and a bit of work in Southeast. So I'm a staff specialist at Campbelltown St. George Hospital. I'm a visiting medical officer at Bankstown Fairfield Hospital. I'm a director of the new clinic in Wetherell Park, Sydney Southwest Respiratory and Sleep Centre, a lead bronchoscopist and pleural service at Bankstown and Campbelltown, and I chair the pulmonary vascular services at Campbelltown. Two main interest areas is lung cancer, because it brings a lot of intervention with bronchoscopy and new modalities of staging and diagnosis of lung cancer, as well as aside of that, I do have big interest in pleural medicine. I did my training in Iraq and migrated, left the country in 2000, and then I escaped to Turkey with my two brothers and my mom and dad, and then we went to Greece, stayed there for 2 years, came to Australia. I'm sure a lot of you went through the same process in a different pathway. Then did the AMC, passed the AMC, did my internship at Liverpool, then basic physician training at Liverpool Hospital, then got a job in respiratory and sleep medicine after I was juggling between cardiology and respiratory. And then I finished my training at Westmead, did 2 years of interventional bronchoscopy at Westmead, then came back to Sydney Southwest to practice and serve the community in Southwest, where there's a high population of our Arabic speaking, in addition to the Assyrian speaking population. In the Weather Park, Bosley Park, all these parks area, as well as Fairfield. I don't have any. Yeah.
Sorry, Fadl, can you use the slideshow mod so we can see your slides better?
What do you mean?
That's the little icon. Just click on that little icon so we can see the slide better.
Okay. So lung cancer.
Sorry, Fadl. Sorry, the slideshow mode.
The last icon at the time there too, on the right side.
Yeah.
On the bottom of your screen, next to the magnify, there's a little icon here. Yep, that's the one.
Yep.
Can you see it now?
No.
Oh, okay.
Yeah.
That's okay.
Yeah, that's the one. That's the one.
Maybe we should do this.
Yep.
And this. Can you see it?
Yeah, that's okay. Go ahead.
So lung cancer, it's when I did this presentation was coming, because I did this 2 months ago, but it's now here. The overview of the talk would be the program, how we started and what's the expectation, how to manage the pulmonary nodules, which is something a lot of GPs are facing these days. And they have been facing, and we refer a lot of patients to the respiratory because of the incidental pulmonary nodules. And what's the evidence of lung cancer screening? And just briefly about the advanced bronchoscopy intervention in lung cancer, because it does marry nicely with the lung cancer screening. The more evolution of the bronchoscopy procedures, because they're becoming harder and harder, and we can't rely on the interventional radiologists all the time because limited resources. Some of them can be tricky. So the lung cancer screening program has been established in collaboration with multiple societies, including the National Aboriginal Community Controlled Health Organization, Lung Foundation Australia, and the cardiologists did have some roles with that, the Heart Australia, the Royal Australian College of Radiologists, and Royal Australian College of Physicians. They all did an important part of establishing the program. And why lung cancer screening? We are not like gastroenterologists. We can't check the sputum for blood. We have very limited way of diagnosis lung cancer without imaging. Therefore, we can't do a standard bronchoscopy because a lot of cancers of the lungs are outside the airways. So they are basically not very useful modality of screening for lung cancer. Therefore, we rely a lot on the radiology, and the good respiratory physician, the one who can read CT scan and X-ray. Lung cancer mortality is very high. It's become one of the leading causes of cancer death in Australia, with almost 9,000 Australians estimated to have died in 2023. It's lethal disease by the time we diagnose it. 65%, 70% of the population by the time we diagnose our stage 3 and 4, where there's limited options, definitely not curative intention. Therefore, the people die from this disease, and they have significant impact on the health because they require multidisciplinary approach in terms of the management. The lung cancer screening program is targeted population who are asymptomatic between the age of 50 to 70 years, who doesn't have any signs or symptoms to suggest lung cancer, who has been smoking cigarettes or has a history of smoking, but quit within 10 years with at least 30 pack. We don't target people who are symptomatic. So chronic cough, people who have hemoptysis, people who had weight loss, there are signs of symptoms of lung cancer. We don't target these populations. We target people who are not symptomatic but actively smoking, or have actively smoked but stopped within 10 years between the age of 50 and 70. And that's a very important message for the GPs when it comes to the screening for lung cancer. There's a lot of resources being put in together in order to make this screening program, which started on the 1st of July this month. So there is a new two bulk bill MBS item numbers for low-dose CT scan of the chest. There is the registry, which everybody's that falls into that category will be registered in this registry. So for future reminder of the CT scan. There is some remote services that delivers the scanner to the areas where there is limited access, especially remote Australia. And we have, the presence of existing low-dose CT scan, the private and public settings. So it's a lot of effort, a lot of stakeholders have been put together in order for the program to run. We have participant recruitment, which is start from the GP. So GPs need to encourage these patients to participate in the program. And then after the participant, then the decision will be made by the requesting practitioner whether to get the patient in the program and start the screening. And then based on the eligibility form, they either can enter or they can either excluded from the program. Then we have a low-dose CT scan, a good radiographer that have a protocol that will basically participate in the program. Then we have a scan assessment by the radiologist, and structured reports will be released to the GPs. The two item MBS numbers, they are bulk billed for low-dose CT scan of the chest. And this is this lung cancer screening in Australia is a bit different from America. America has been doing the program for much more longer than us, and they do it on a yearly basis. We do it on 2 yearly basis. So we do a CT scan for this patient 2 yearly basis for over the course of like every 2 years. Until they reach the age of 70. But most of the time, we actually continue. And, you know, as a respiratory physician, I do a lot of CT scan on the patient. That's because I see a lot of lung cancer. So I'm a bit biased about which patient, when to stop and when to continue. And, you know, everybody's got this single unique code for item numbers to be referred, whether it's GP specialist, non-GP specialist. We have a registry now, so everybody gets into the program can be registered, which is national led cancer screening registry, and that's in concordance with the National Bowel Cancer Screening Program and National Cervical Screening Program. It comes at the end by the nodule management protocol. Lung cancer starts with pulmonary nodules, and these pulmonary nodules, majority of the time, they are benign, but however, when we find them, it brings a lot of anxiety to the patients because there could be an early signs of early stage lung cancer. And some of them can be very small and it's hard to biopsy them, but sometimes they can be very obvious, these pulmonary nodules, and can be easily accessible. So there are some reports that have been recommended to utilize when it comes to the reporting of the patients with the pulmonary nodules. And the standardized reports' idea is to improve the accuracy of the report, clarity and readability, and clinical utility, completeness, and reporting efficacy or efficiency. And, you know, the Australian New Zealand Society of Radiologists with the Thoracic Society of Australia and New Zealand worked collaboratively in order to come with the report that is actually fulfill the above criteria. When it comes to the pulmonary nodules, there should be some protocol in order for us to manage these pulmonary nodules, because not every pulmonary nodule is biopsiable. Not every pulmonary nodule needs to be followed up. But there is specific criteria where we should be monitoring these pulmonary nodules. So there's a lot of models that been designed to assess the risk stratification for these pulmonary nodules to be malignant or potentially malignant. And one of the best modules that actually has been established is the PAN-CAN module. The PAN-CAN modules, it's an automatic generating of the risk associated with the presence of the pulmonary nodules, and that looks at multiple factors, including age, gender, family history, emphysema, the size, the factors that are specific to the pulmonary nodules, and this will include the nodular size, type, location, presence of the speculation, and total count. And this was derived from the Canadian Early Detection of Lung Cancer Study, which basically looked at more than 12,000 pulmonary nodules. The lung nodules can be comes in different category. They can be ground glass pulmonary nodules, as you can appreciate here. This is a ground glass pulmonary nodules. This is unlikely to be malignant, and this will be categorized as a category 0 pulmonary nodules. That's usually we recommend short interval follow-up in 1, 2, or 3 months to make sure everything is disappeared and there's no residual cancer hiding between these ground glass changes. The other pulmonary nodules we see is the solid and semi-solid, which are the more concerning one because they are the one which can potentially become or can be a harbor of malignant cells. When we looked at the pan-nodular calculator, according to the characteristics mentioned earlier, they can classify into the category 1, where basically patients got small pulmonary nodules. There's no any other major risk factors. They need to be followed up to 12 months, 2 years with the low-dose CT scan. Then you have category 2, which requires 12 months CT scan. And then you have category 3, which requires 6 months. So the higher the category, the higher risk of this pulmonary nodules to be malignant, therefore the shorter interval of screening between the CT scan. Once the likelihood of the pulmonary nodules to be cancer or more than 30%, then this type of nodules are categorized to be either high risk, category 5 or 6, and they require a lung cancer multidisciplinary team referrals because they usually require PET scan plus minus biopsy or treatment if the biopsy is a high risk. So when the patients felt to have a pulmonary nodules and been classified as category 1, they have 2 years CT scan until they reach the age of 70. When they're category 2, you do 12 months CT scan. And if after 12 months CT scan, the pulmonary nodules remain the same, they go back to the category 2. And the patients can be upgraded to category 1, category 2 if the pulmonary nodules remain stable on serial imaging. So if you have somebody who had a pulmonary nodules, for example, 10 millimeter, and you do a CT scan of 3 months, and then they fall in the category 4, and then after 3 months, the pulmonary nodule is stable, they go back to category 3. So they require, the next scan will be 6 monthly. So demonstrating the stability of the pulmonary nodules over the course of the time warrants downgrading the category to either to the one before. The change in the size of the pulmonary nodules is also an important factor when it comes to the pulmonary nodules. So if they start becoming spiculated, they become larger. That's a worrisome sign, and they require a very careful monitoring because there could be a sign that there is evolution of the cancer in these pulmonary nodules. So this is the recommended or suggested module of investigating these patients. So we can, see very low risks, low to moderate risk, and moderate risk, and then high risk. The high risk will need referral to an early intervention and discussion of the NDT. The one we really have issues with them, the low risk, they need follow-up after 2 years. The one with the low risk to the moderate risk, they require a careful monitoring with the serial CT scan, and upgrade them or downgrade them depends on the size of the pulmonary nodules and the stability of these pulmonary nodules. Evidence. The evidence comes from the early stage of lung cancer screening, where they start using a CT scan of the chest. This was a study that actually looked at in 1990 or early 2000, and that looked at the lung cancer screening. The low-dose CT scan shows to detect small early-stage lung pulmonary nodules more effective than X-ray. X-ray, when it comes to pulmonary nodules, is useless because it doesn't give you a good measurement of the pulmonary nodules. Secondly, it doesn't give you a good analysis of the shape, whether it's spiculated, rounded pulmonary nodules. Doesn't give you a good relationship of the pulmonary nodules to the airways if you want to go on biopsy. This was only one single arm study, and they looked at one group of patients. There was no control arm. There was no people who didn't have a screening, and therefore mortality assessment was not beneficial. So one of the downside of this study. Then there was another study in 2002, in USA, where they looked at the National Lung Cancer Screening Trial. They looked at more than 14,000 patients, and efficacy of the lung cancer screen using low-dose CT scan versus chest X-ray. The low-dose CT scan was effective in reduction of the lung cancer screen by 29%. So again, low-dose CT scan much more effective than chest X-ray. Don't worry about this one. I think we just go to the biggest international lung cancer screening trial, which is still going. They basically look at two important outcomes. They compare the accuracy of the risk stratification against the US Preventative Services Task Force criteria for detecting of lung cancer, and evaluate the nodule management efficiency using the PAN-CAN nodules probably calculated based protocol versus lung RADS protocol. This protocols was heavily influenced by the National Lung Cancer Screening Program. So this is the early results of this. There's more than 10,000 populations were screened, and around 4,500 were enrolled. And what they found, the low-dose CT scan detect cancer in 203 patients. The proportion of the people who have been detected by cancer is small. However, bearing in mind this is a very lethal disease, and early detection of these patients makes a huge difference. I think this is just a repetitive. So basically, one of the things we look at when it comes to the lung cancer screening is we look at the PAN modules of assessment of risk. Look at the age, gender, the size of the pulmonary nodules, the presence of visiting and family history, and then this is a computer-generated risk stratification, and then depends on the size. And this and the PAN score, we can determine where the patient falls in terms of the risk stratification, and what type of modality in terms of the serial screening would they know, or they need to have at what interval period of time. There's been a big huge enrollment of the patients in this program, and so far we actually found that there's a lot of cancer or suspicious pulmonary nodules have been detected in these populations. So I suspect we're going to be very busy in respiratory medicine because of this lung cancer screening. The question whether the country is prepared for it or not, that's something we will find with the time. I just want to briefly talk about the advanced pulmonary intervention, something maybe or may not be a lot of you have heard about them. This is a case of patients which I saw at the Rapid Access Clinic, which I chair in Campbelltown Hospital, which is a lung cancer clinic. She has no symptoms. However, the GP, when examined her, he found her to have digital clubbing. She's a heavy smoker, started from the age of 20, and she was still smoking by the time I saw her in the clinic. Occasional alcohol uptake. Father had some brain cancer. She had one of the nicest clubbing that I can see textbook, which concerns us as a clinician, whether there is in a smoker that this is potential a marker for something more serious. The GP correctly did a CT scan of her, which demonstrated a big right upper lobe mass, as you can appreciate. There's more than 3 centimeters. Very concerning findings. She underwent PET scan, and that shows quite intense avidity of the right upper lobe mass. Interestingly, it did show some uptake in the paratracheal lymph nodes, which is one of the thoracic lymph nodes that drain the lymphatic system in the thoracic cavity. And these lymph nodes are basically quite commonly involved if there's nodal metastatic lung cancer. So what would you do as a next step in terms of the diagnosis? Would you go CT-guided biopsy? Would you do, it's reachable via CT-guided biopsy. Would you do bronchoscopy? Would you do something else? We did a bronchoscopy with linear and radial probe ultrasound. And I wanted to get a diagnosis by reaching the mass at the same time, sample of the mediastinum to stage her, because she can potentially be a curative intent person if there's no evidence of nodal metastases. We did full staging of the mediastinum with the linear probe ultrasound in the bronchial ultrasound, and that looked at the N3 disease on the contralateral hilum, mediastinal lymph nodes, as well as the ipsilateral hilar lymph nodes, and they were all clear, despite the station 4R was avid on the PET scan, didn't demonstrate any evidence of uptake or no evidence of malignant cells. However, I went with the radial probe and biopsied her mass at the same time in one procedure, and we found adenocarcinoma moderately differentiated with PDL1 of 10%. Her CT branch shows no evidence of metastases, and she had surgical intervention which basically she's, and we just reviewed her biopsy last week in our MDT meeting, and she has clear margins. And there's the sampling of the lymph nodes and the mediastinum shows no evidence of any metastasis. So she's being cured. The question is how long. Depends how whether she continues to smoke, whether there is recurrence. So sampling of the suspected lung lesions depends on the nature of the lesion, how proximal these lesions to the airways, whether there's underlying lung disease, availability of documents, and the human skills. Not everybody can do radial EVAs. Not everybody can do linear EVAs. Not everybody can do CT-guided biopsy. So it could be challenging when it comes to the peripheral pulmonary nodules, how to sample them. And with the lung cancer screening, we see a lot of these. So we need to be prepared with the skills in terms of and equipments and theater times, endoscopy time to know how to biopsy these lesions. Therefore, the endobronchial ultrasound has gone and played a significant role in and becoming a standard of care for patients with lung cancer. The ultrasound has been modified through the linear probe and the radial probe. The linear probe is basically the one plane view of the structures around the airways. That it's a bronchoscopy that has the ultrasound at the tip of it, and with the contact of the airways, you can see the whole mediastinum. Actually, you look at the lymph nodes, the major vessels of the mediastinum, the heart, and we do sometimes do EVAs through the esophagus as well, and biopsy the lesions that are close to the esophagus much easier than the airways. So it's a modality that actually added a significant impact on the staging and accuracy of staging of lung cancer, because proper staging gives you a better idea about the prognosis.
Sorry, Fidel, I may need to interrupt here. So if you have if you can go through the slides, or you have a conclusion slides, you have 1 minute. So we open up the floor for questions, if you wouldn't mind.
Yeah, sure.
Sorry about that.
It's all right. So the key messages when it comes to the lung cancer screening is the lung cancer screening is here. Encourage patients to enroll. As a GP, you will be the front lines in assessing and enrolling these patients. And pulmonary intervention is on the horizon with more advanced techniques in sampling and staging of lung cancer. I don't know how many of you are GPs, but we have rapid access lung cancer clinic in these hospitals, Liverpool, Campbelltown, Bankstown, and this is the criteria which may or may not be helpful for you in terms of when to refer these patients based on the CT scan. So yeah, I think that's pretty much it.
Excellent talk. Look, thank you very much. And I'm sure there will be plenty of questions to ask. We open up the floor for questions. Please do.
Yeah. Can I start? Dr. Fidel, thank you very much for this very excellent presentation. I know we are restricted by time. I have two questions. The first question, Fidel, is about resources. We know from the experience of the National Bowel Cancer Screening Program that this put a huge load on the endoscopy units, on the endoscopist, because as you know, every positive fecal occult blood testing is a colonoscopy with the priority A within a month, right? So I think with this screening, do you think there is enough resources from the bronchoscopy point of view, which allow you to go together smoothly with this program, which can be in stages, obviously, like our program? It started with the stages, limited stages, right? So that's one question. And I have one question about the risk factors.
So, Ahmed, I don't think there's enough. Actually, I fight with the. I mean, I just sent an email today about the exec and the hospital management at Bankstown, because we only have half a day list in Bankstown. And with these procedures, when we do linear and radial, they take time. We need a fluoroscopy on site. And now we're going to start doing robotic bronchoscopy and combi and CT scan bronchoscopy. And this takes time. And, we don't have time for these patients. We try to do as many as possible released, but usually we end up canceling 1 or 2 because of the lack of time. And I actually don't know how the government or the country will be prepared to fulfill the demand of this. And I think people with the time, they will realize that, you know, we need more time for bronchoscopy. The problem is the anesthetic cover as well. Seems like in Sydney Southwest, actually even in Sydney Southeast, we struggle with the anesthetics availability, and these procedures needs to be done under either deep sedation or complex one under general anesthesia. So we are struggling with that, and I don't know how this is going to end up. I don't know. I mean, really, I mean, ideally, these patients with lung cancer needs to be investigated. The standard of care for lung cancer from the time of referral to the time of the diagnosis, you should have 4 weeks. The patients needs to be treated, and this is not national but international recommendation.
I have a question, if you wouldn't mind,
Sure.
Fadel. Any screening test should be easy to do, and for me to have a CT scan, CT chest for every person, I think that's a lot of money spent. I love to have a CT coronary angiogram for every patient of mine above the age of 40, and I'll have a lot of work afterwards. So those patients need to be investigated further if we identify coronary artery disease anyway. So to have a CT scan of the chest to every patient, what is the first question is, what is the sensitivity and the specificity? You will find a lot of small nodules, and what does that small nodules mean? And you probably need to follow this up with a number of scans every 2 months, every 3 months. That's more and more scans. And the second question is, what is the number need? So number to treat, so number need to treat. So if you save one life, how many CT scans you do to save one life, if you have an answer for these questions?
So, I mean, the low-dose CT scan is very sensitive in picking up pulmonary nodules, and the sensitivity approach to 85 to 90%. Now, the specificity... But
how specific is this?
So the specificity is, I mean, it detects pulmonary nodules, doesn't tell you whether this pulmonary nodules is malignant or not, because I mean, you need to sample these pulmonary nodules. There's some criteria that increase the specificity that this can be malignant, and that's the upper lobes pulmonary nodules, the speculation, and the size. And in the presence of the above criteria, actually the specificity becomes almost 90 to 92%. Now, how many patients needs to be treated? A lot of patients needs to be treated. Well, a lot of patients needs to be, as you saw on the slides, where the participants were approaching 5,500 patients, and you only picked up lung cancer in 200 patients. And these were the patients where has an solitary pulmonary nodules further investigated and found to have a cancer. So you do need to, having said that, this is a national lung cancer screening campaign is still running, and we don't know what the future holds. But you do need to scan a lot of people to save one life, basically. I need to look at the paper again and give you the exact numbers of the number of patients needs to be scanned to pick up a cancer. But I mean, the proportion of the number of patients that needs to be scanned is large. But again, keep in mind, this is a lethal disease. If you pick it up, it makes a huge difference to the prognosis of the patient.
And that's why
this might change with the time because we're still enrolling people, and this data is a very primitive data, and I'm sure with the time they will see much more cancer. I mean, I do see a lot of cancer, and this is because there's a lot of patients having more scan now than they were before, and the proportion of the patients then up to have cancer on this that being referred to me based on the criteria in the page here. I would say, to be honest, almost 90% of them end up having cancer, whether it's big adenocarcinoma or aggressive carcinoma.
Dr. Ali, there is a question from the chat. He is from a very close friend of mine from UK, Dr. Salam Farhan.
Dr. Salam Farhan asking questions. How frequently would you recommend a CT scan chest? Yearly, 2 yearly, after scan done and clear for a smoker?
So the national screening program is 2 yearly for Australia. American, they do it yearly. Actually, I do. I mean, if the pulmonary nodules are small, show stability, I usually go 2 yearly. But the asymptomatic, according to the guidelines and the national cancer screening, is 2 yearly here. Now, when do you stop? That's the $1 million question. Would you stop at the age of 70? Would you stop at the age of 80? Would you stop at the age of 75? I actually don't know. I mean, the patients who've been targeted in the lung cancer screening program is between 50 and 70. So technically, after 70, you should stop the screening. But would you be happy at the age of 65 if you find pulmonary nodules and then leave it because the patient, by the time you do another CT on 71? The answer is no. So as long as the patient is smoking, I'll just keep screening them. Now, until what age, it's hard to know. I don't know, Ahmed, what time do you stop bowel cancer screening?
Well, yeah, I think for bowel cancer, it's more straightforward there, where we start initially, the National Bowel Screening Program started from the age of 50, second yearly to the age of 74. But now with the advance of the cancer in younger people, this program dropped the year to the 45. Now this program is starting from 45 years old in the program, but the recommendation is for any person between the age of 40 and 45 in Australia to do the second yearly fecal occult blood testing through his GP. So we got a limitation, but this limitation comes from the very well recognized growth rate of adenomas to cancer.
Yes.
So we know that. We know simple adenoma needs around 7 years to develop into adenocarcinoma. The sessile-serrated adenoma probably faster, maybe between 3 and 5 years. So knowing from this, 74 is good age to stop. And that's probably put a question to you about the nodules. What do you mean by nodules? What the pathology of the nodules? I mean, on all these studies you have, are they a precursor of cancer or are they early cancer? What do you mean by the nodule?
Nodules is basically a lesion that is present in the parenchyma that exists in the parenchyma of the lung that shouldn't be there, and that could be in a form of ground glass where you can still see the blood vessels through it, or a solid lesion. The nodules can be. The people can get pulmonary nodules for different reasons, and people who had infections before, they end up with some pulmonary nodules. TB can give you a lot of pulmonary nodules. When the nodules is calcified, we are reassured. And to be honest, most of the pulmonary nodules, they are calcified. I don't wash them. But the pure, irregular margin, speculated pulmonary nodules in a smirk usually makes me anxious. This is an early stage cancer. And therefore, I do recommend to have a scan to monitor the size of this pulmonary, because there's no other modality to tell with the time this is going to be cancer or non-cancer. And nobody can say that.
Sorry, I have a question. Can I ask
have a question
Dr.
too.
Sorry, go ahead, Dr. Bishra. Go first.
Dr. Fidel, thank you for the great information. I'm thinking there's a lot of difference between the colon cancer screening, which everybody received by mail. They send it to random samples. They send it to everybody in New South Wales. So how do you guys catch the early lung cancer? Do the patient, like the heavy smokers? So how do you do the screening?
So we basically look at them and assess them. If they fall in between the age of 50 and 70, we send them for low-dose CT scan. Now, according to the low-dose CT scan, I mean, we ask the patient, why do we do the CT? We tell them we do the CT scan because we want to assess them, for lung cancer screening, because you're a heavy smoker, you're not symptomatic, and there's a new guidelines or new screening program that has been established in the country to use it. And then once we get the CT scan, we look at the pulmonary nodules. And then depends on how big the pulmonary nodules, whether it's solid, soft-solid, or ground glass, we monitor in terms of, if somebody comes with the CT scan shows 3 centimeter mass in the right lung, this is cancer, to prove it otherwise. And that cannot be left.
So they are referred by their GPs. How
yeah.
does the referral?
Yeah,
how
yeah.
does the screening process? How it started?
Yeah, so the GP now have, there's actually, I'm happy to send you, there is the Lung Foundation, they have a screening, the process, the module of how to screen them. It's a registry. You basically put the patient details and, put there that you're going to start the screening with a low-dose CT scan. And once that's been, the patient's been entered into the data of the registry, then it's basically automatically
Okay.
a reminder to do. It's like same like bowel cancer, basically.
Okay. Oh, thank you.
Dr. Wissam.
Hi, Dr. Fadel. Thank you for the presentation. Great presentation. Look, I'm a radiologist. I do a lot of CT scan, and I see quite a few of these nodules.
Yeah.
Yep.
Wissal, you are muted. Can you unmute, please?
Oh, I'm muted. I'm sorry. How about now? Can you hear me now?
Yeah.
Oh, great. Yeah.
Very good.
So I see quite a few of these nodules. You mentioned size. So you're talking 6 millimeter and above, and you mentioned density. What's your approach for ground glass opacities? Because we see quite a few of these, and sometimes you biopsy them and you get back malignancy, you get back worrying results. So my understanding from the lecture that ground glass are low risk.
Yeah.
But we do get positive results out of these ground glass. And size, what's your cutoff size to say, I don't need to worry about this nodule? I know from attending lectures, they mentioned 6 millimeter. But between 5 millimeter and 6 millimeter, sometimes it's really hard. Where do you put your cursor when you do the measurement? So when do you start to worry? When do you start to say, I will follow this up? I know there is a straightforward cancer nodules, which no doubt.
Yeah.
The gray area, those small nodules, ground glass appearance, how often do I follow this up?
Yeah, so ground glass historically, if they persist for a period of time, they are usually lipidic adenocarcinoma. And lipidic adenocarcinoma is a benign type of lung cancer. It's less aggressive than adenocarcinoma. So, anything above 6 needs to be assessed by a respiratory physician. Not every 6 millimeter pulmonary nodules needs to be biopsied. Now, if the pulmonary nodules remain 6 according to the CAN sort of modules, then they just do regular monitoring until they reach the cutoff of 2 years, and then until the age of 70 according to the national guidelines for lung cancer screening. If it increases in the size, for example, you have 6 millimeter pulmonary nodules, after 3 months becomes 8 millimeter or 9 millimeter, that's worrisome because there's something happened here. The things that grow, they indicate some problem. And therefore, we usually do is we usually do a PET scan to look at the avidity and assess the mediastinum. But most of the time, let's be honest, when we do PET scan for these ground glass pulmonary nodules, because they are benign form of lung cancer, we see a lot of low avidity. But despite that, we biopsy them. And to be honest, from my experience, most of these ground glass pulmonary nodules, they end up, I think more than 90%, they end up with lipidic adenocarcinoma. It usually comes with multifocal. So if you have somebody who's got ground glass changes with the clear margins and multifocal in a smoker, it's very worrisome. This is a lipidic adenocarcinoma. Now, when to biopsy? I usually biopsy when they're approaching the size of 1 centimeter. How often do you monitor? How often do you monitor them? I monitor them until the age of 70. If they grow, I biopsy them. And when biopsy them, I can tell you 99.9% of them, they become a lipidic adenocarcinoma. Now, there is this diffuse ground glass changes one, which looks like a consolidation. They're usually inflammatory and infected. Therefore, they need a very short interval. They usually classify as category 0. They usually need an interval scan after 1 month or 2 months to make sure everything is resolved and nothing harboring behind these ground glass changes, especially in the smokers.
How about like now, how do you deal with the AI scanning? So they pick every single density.
Yes.
So you end up with tens and tens of these nodules that they
We
pick
do.
throughout the lung.
We do.
So do you
We
have
do.
to describe every one of them?
Yes, I mean, they usually needs to be assessed by a radiologist, and measure the size of them, and then you monitor. I mean, if they're all less than 6 millimeter, you just need to watch them and repeat the CT scan and see which one grow, which one stay the same size. It becomes more complex when you have multiple pulmonary nodules. But yeah, I mean, no matter what the size is, if the patient is smokers, they still need to be screened. If they have somebody who had 3 millimeter pulmonary nodules, I usually do a screening after 2 years. If they're not,
but if it's over 6, you'll do it in 1 year.
Yes, over the age of 6, I usually do after. I mean, there's something called splash nurse guidelines as well for monitoring of the pulmonary nodules. Usually within 6 to 9 months, up to 1 year. If they grow, then it makes you more concerned. Then you reshorten the interval, or even consider another modality of investigation with the PET scan plus minus biopsy.
Thank you so much. I appreciate it.
It's all right.
Thank you very much. There is a question in the chat from Mariam. Mariam, do you want to ask the question yourself if you like, or you want me to read it? I'm happy either way.
I'd love to read the question firstly. Thank you, Dr. Fidel, for your presentation. It was very insightful. Now, throughout the presentation, you touched a little bit on the linear EBUS.
Yeah.
Now, giving its diagnostic value, particularly in the mediastinal staging, that's what you stated. How do you see the role of linear EBUS evolving in routine clinical practice? And what are the key skills for junior doctors like myself to become proficient in this technique?
So linear EBUS is basically sampling of the mediastinum. We can access most of the lymph nodes in the mediastinum. We can access the paraesophageal station, the aortopulmonary nodules, and some places actually don't do trans aortic biopsy of these lymph nodes, but we don't do it in Australia yet. The EBUS, I mean, I think there was a slide which I actually wanted to share it with you, and I just wanted to tell you how the EBUS makes difference in terms of the diagnostic, in terms of specificity and the sensitivity. I mean, they looked at the study of linear EBUS versus PET scan. We didn't have linear EBUS 20 years ago, 30 years ago. They usually used to basically do PET scan, or even look at the CT scan. If the lymph node is more than 1 centimeter, they say it's probably involved, and this is treated as stage 2 lung cancer, stage 1 lung cancer. If the PET scan is positive, they say it's probably it's involved. They would treat it as a stage 3B or 3A, whatever. But now with the presence of the EBUS, the sensitivity and the diagnostic accuracy of linear EBUS for staging, full staging, and detection of the micronodal metastasis is approaching 98%. And that's why it becomes a standard of care with the sampling of the lymph nodes. Now, if you look at the literatures, they say anything more than 3 centimeters should have full staging of the mediastinum, regardless what the PET scan shows. But actually, there's some cases of micronodal metastasis, even with the small pulmonary lesion, which is proven to be cancer. And we talk about 1 centimeter, 1.5 centimeter, 2 centimeters. So I think what's going to happen in the future, that the linear EBUS will be a standard of care for any suspected lung cancer. If we want to see if this patient's curative intention, to have it as a part of the routine workup for lung cancer. Now, in order for you to become a good bronchoscopist and EBUS trainee, then the Thoracic Society of Australia and New Zealand, they do recommend to do at least 25 independent with some supervision of an accredited respiratory procedures who does EBUS regularly, and also undergo what we call a self-assessment task in 2 stages. And if you pass and you do, you have a logbook of the completion of this, then you should be able to practice EBUS independently.
Right.
Does that answer your question? So
Fantastic. Yes, perfect. Thank you so much.
Dr. Mariam, sorry, are you a respiratory physician or trained?
Oh no, I'm a current medical student.
Medical student.
we need respiratory physician who speaks Arabic to help me.
Too early.
I'm struggling here.
By the time you'll be training, there will be heaps of other different things. All right.
There will be other interventions. Yes.
I mean, we have a lot of intervention. I mean, I didn't touch about a lot of intervention. We actually have combined CT scan where we do CT scan when we do biopsy of these pulmonary lesions. And this gives us a diagnostic accuracy of being in the lesion 98%. And that's basically showing the scope is in the middle of the lesion when you're biopsying it through the CT scan. It's an amazing modality.
So in the future, do you think the current interventions will develop in a way to challenge the main bottlenecks or barriers in the current pathway that delay the diagnosis or limit the access to timely intervention?
Yes, absolutely. I mean, the intervention, I mean, the respiratory intervention, it takes time because first, we don't have a lot of people trained. Secondly, because of the public hospital, nothing happens quickly. Thirdly, because, it requires a lot of people who have been trained in it. Or needs a lot of training, especially with the new modalities. It becomes really very, very challenging, and not everybody can do it. You need to have at least a fellowship in intervention, and you should have you should fulfill the criteria and the logbook that makes you qualified to safely practice these procedures.
Fantastic.
Dr. Ali, thank you very much.
That's great. So we're just about to bring the meeting to conclude here. Probably, I mean, by the question, Fidel, do you get any sort of competition from radiologists, interventional radiologists, to do your procedure?
No, really. I mean, they're very helpful. I usually ask them to do something which I can't do, or I think it's risky to be done under general anesthesia. I mean, it depends from one center to another. I mean, with all my respect to my colleagues radiologists, some of them have more courage to do things, more brave than others to do things, and that comes with the practice. I mean, I had patients who had a
beautiful, excellent. So we're going to bring the meeting to a close. Thank you very much for the two excellent speeches tonight, and we hopefully meet again probably in a month's time. Thank you very much. If there's any more questions, burning questions, we're all done for tonight.
Thank you very much. Thanks a lot. Great talk.
For the next session, it'll be dermatology, by the way. Next session in a month's time, it will be on dermatology. Thank you very much. Thanks, Dr. Rima. Thanks, Dr. Fidel. Thank you very much.
Thank you.
شكرا جزيلا. شكرا.
Thank you, everyone.
Thank you.
Have a good night.
مع السلامة.
على خير. مع السلامة.
السلام.